Okay, here's lesson 22 in the EMT course, and we're into some altered mental status cases. The first one we're going to talk about involves glucose. So we'll do some online study here, and then we'll spend a fair amount of time in lab dealing with altered mental status, particularly those that are related to blood glucose. These are very common cases, and so we want to make sure you're well versed in the whole situation there. Content of this presentation, pretty simple outline, some physiology stuff. We're going to talk about the disease of diabetes, and then talk about altered mental status in general, and how do you assess and treat altered mental status, particularly related to glucose. And we'll have subsequent lessons on the other causes of altered mental status. So what's the deal with insulin and glucose? Well, cells need a continuous supply of oxygen and for glucose so that they can do aerobic metabolism. Aerobic metabolism is the efficient way for cells to make energy, as opposed to anaerobic metabolism, which is very inefficient. It continues, it's producing some energy, but aerobic metabolism, when you have oxygen, allows the energy to be made in a much more efficient way. So basically, bottom line is cells need glucose inside the cell. Brain cells particularly utilize energy really at large rates, high rates, and they can't really store any oxygen. And so it has to be delivered to them just in time. So the processes of circulation, ventilation, oxygenation deliver oxygen and glucose to cells, particularly brain cells, just in time for them to use them. So the problem here is that insulin is necessary in order for glucose to get into the cells. The glucose molecule doesn't get into the cell on its own. It needs insulin to unlock the door in the cell, so to speak, to allow the glucose to enter. So you can have tons and tons of glucose circulating around in the blood, but if it's not in the cells, it doesn't matter. So glucose levels in the blood are not as important as glucose levels in the cells. And the way for glucose to get into the cell is that insulin unlocks the door to the cell and allows the glucose to come in. So insulin is secreted by the pancreas. Diabetics take insulin externally. That's artificially produced. But if you're non-diabetic, and even if you're a type 2 diabetic, your pancreas is where insulin comes from. So let's talk about type 1 and type 2s. Type 1 patients' pancreas has stopped working. It is not secreting insulin, so they must have an external source. In the type 2 diabetic, which I think is probably a little more common these days, at least in my experience, I see a lot more type 2s than I do type 1s. The type 2 diabetics, their pancreas is still working. It's still secreting some insulin, but either it's not secreting enough insulin, or the insulin it is putting out is not operating effectively. And the term insulin resistance comes up here. So the door's not opening, the key's not working to the lock effectively, or there just aren't enough keys circulating around in order to get the glucose into the cells. So how do they deal with that? Well, type 1s take insulin injections, sometimes just in the morning, sometimes a couple times a day, sometimes right before they eat. They estimate what they're going to eat, or sometimes right after. More and more patients now have insulin pumps. Insulin pumps are probably better for the patient in that they secrete insulin like your pancreas does, a small amount throughout the day. But remember that the thing with these pumps is that they are not testing or sensing or measuring blood glucose. They're just delivering insulin. So even if you don't eat enough, your pump continues to put insulin into your system. And so we can run into patients that do have insulin pumps, which, and the patient is still hypoglycemic. So anyway, these pumps are usually worn around the belt area, and they're small, kind of the size of what a pager used to be, if anybody remembers pagers. They're not large at all, and they secrete insulin through a very small needle that the patient places under the skin, and usually in the belly. And so pumps are something that we run into more and more often. At the BLS level, we're not messing with the pump. The fact that a patient has a pump is meaningless to you at the BLS level. We're not going to teach EMTs to decide whether to whether to turn off the pump or to mess with the pump in some way. We're simply going to leave the pump alone. Type 2 diabetics won't have a pump. They don't take insulin. Type 2 diabetics take a medication that helps the insulin act more appropriately, increases the effectiveness of the insulin in that type 2 or insulin-resistant diabetic. And there's a whole boatload of those. Some of them start with GLUC, and which might give you a hint as to what their name is. The generic names, unfortunately, don't really. But there's a number of meds that they take, and there's new meds coming on the market all the time. So just realize that type 1s take insulin, type 2s don't. Type 2s either manage with diet control, or in many cases, they're on an oral medication to help make their insulin more effective. So what we're dealing with here with altered mental status is a number of causes, and we have in the past and still will talk about mnemonic, if it helps you at all, to remember the possible causes. But that mnemonic is AEIOU TIPS, TIPS. We'll go through that in a subsequent lesson, but I just wanted to give you an overall look at the number of things that can cause altered mental status. And the top of the list has got to be hypoxia and shock. And then very commonly, our patients are using drugs or alcohol. When I say drugs, again, I mean street drugs, not prescription medications. Then an accidental over-medication of prescription meds can be a factor here. A patient gets confused, doesn't remember if they took their meds, so they know they better take their meds, so they take their meds, but it turns out they already took their meds, and so they've accidentally overdosed themselves. Could also be body temperature, could be a massive systemic infection, a sepsis going on, could be something neurological causing altered mental status, could be something psychiatric or behavioral. And at the bottom of this list, but certainly not at the bottom of your thought process, is an altered blood glucose level. I think it would be absolutely safe for you to consider that in any patient with altered mental status, even if you think you found hypoxia and shock, even if you're very sure that the patient has drugs or alcohol involved, even if you're very sure the body temperature is way high or way low, even if you're very sure this is a neurologic thing or a sepsis thing, or if you're really, really sure this is just plain psychiatric behavioral issues, an altered mental status should get a check for a blood glucose level in every single situation. So then what would a patient with an altered blood glucose look like? What would they act like? Well, there's hypoglycemia, meaning low blood glucose, and then hyperglycemia, I'll talk about here in a minute. Hypoglycemia assessment, your patient looks shocky. They used to call this insulin shock. Fortunately, we quit calling it that. But the shock piece of it still makes sense. Your patient will typically be pale, not always, but typically. Your patient will typically be sweaty, maybe even diaphoretic, extremely sweaty. They're altered. And altered in this case, we're not talking about an altered level of consciousness, although that can be the case as well. But altered mental status is different than altered level of consciousness. Altered mental status means that the patient is angry, grumpy, sleepy, confused, maybe dizzy, maybe nauseated. They appear intoxicated. That's what the altered mental status in blood glucose issues looks like. How are you going to know what's going on? Well, your history of the present illness, your HPI, and a physical exam. A real physical exam, but that's got to include blood glucose. So vitals and everything else. And, a decent physical exam where you're looking for other signs, symptoms, maybe history clues, maybe a medical alert bracelet or something, maybe some hard candy in their pocket, maybe, who knows, maybe an insulin pump, but a reasonable physical exam while someone else is getting you a blood glucose test, because that really is the number you're looking for. And this is one of those assessment things where you can have an objective number. If their blood glucose is low, it's low. And if it's high, it's high. And the way to find that out for sure is to use your glucometer and get a good blood glucose test. It's quick and usually easy to do. Then the other thing I want to make sure we understand is that hypoglycemia can look like other things. And the classic two things that hypoglycemia can mimic is that a hypoglycemic patient can look like they're having a stroke. They can have facial droop, they can have slurred speech, they can have weakness, and it can look just like a stroke. So anytime you think your patient's having a stroke, you need to rule out that it's really low blood glucose causing it. And they can look intoxicated. And sometimes they have the smell of alcoholic beverages on their breath. And so then it's further complicated. But the objective test is a finger stick blood glucose measurement. So then what are you going to do? While you're assessing this and verifying that glucose is at least one of the patient's problems, airway positioning, jaw thrust is the appropriate thing. I don't think these patients need oral airways and nasal airways very often. It seems like this is a rapidly reversible cause of altered level of consciousness, which is causing them the airway problem. And so my judgment is that most of the time I can manage these patients with just a jaw thrust or placing a pillow appropriately and a good airway position, a good sniffing position for the airway. Manage your oxygenation. There's nothing about low blood glucose that would alter your O2 therapy, so use that pulse oximetry, verify it's a valid signal, verify the patient's not hypotensive, which may be giving you a low reading. But if you have a low pulse ox reading and it's due to hypoglycemia, your O2 protocol should direct you toward high flow and high percentage oxygen delivery anyway. So the airway and the O2, same as always. The patient that's hypoglycemic is not going to be hypotensive from the hypoglycemia. They may be hypotensive for another reason, but it's not the glucose. There's nothing about low glucose that's going to cause you to have a low blood pressure. So you want to, CVO, your standard stuff, CVO, manage that. And then we're going to give glucose. Now, the patient that is alert and able to hold a glass and drink some orange juice or something that is, high in sugar content, that's fine. If they can hold it and drink themselves, that's great. That's a more normal way. If they can eat a snack, let's go for it. But in most cases, why have they called us if they just needed to get something to eat or drink? And so in some cases, that will be the appropriate way to do it. Have the patient eat and drink, raise their glucose the usual way. That's a slower process, but whatever, that's the best thing for them. If not, then we'll need to use some glucose paste, and we'll talk about glucose paste in the lab setting. But it's not oral glucose. It's actually buccal or buccal, depending on how you want to pronounce it. It is a pinch between the cheek and gum. That absorbs much more rapidly than if they swallow it and they have to essentially digest it. And then the ALS providers can go with an IV or IM, intramuscular. They can go with that route. In some cases, the family patient or patient's caregivers and such will have a glucagon injection that they can give. And what that glucagon injection they give IM, what that does is it releases glucose that's stored in their liver. And so that wouldn't mean that they would have to have sufficient stored glucose in their liver. So your malnourished patient, not a good candidate for success with IM glucagon. There's no reason not to try it, but we shouldn't rely on it. But really, this is kind of more for the ALS folks. I just wanted you to know the full spectrum of care here and what happens. And we have limited tools at the BLS level. The fact that the family can actually give something that the ALS folks give, it kind of means that in those cases, the family may be ahead of what we can do. But glucose paste or a snack or something to drink, preferably high glucose content. Remember that diabetics will typically have diet soda in their house, so a glass of Diet Coke doesn't raise your blood glucose level. And so orange juice or something like that, if they can hold it and if they can drink it themselves. Glucose paste, mentioned just a second ago, this is not oral glucose. This is glucose paste. We want to give it buccally. We want to give the whole tube, a little pinch at a time between the cheek and gum, and let it soak in rapidly there. You can get an excellent route of administration is the buccal route, a pinch between the cheek and gum. That's why chewing tobacco works. This works gradually. It may take 10, 15, 20, maybe as much as 30 minutes. It's logistically challenging because these folks are drooling, and you want to use small squirts of this tube because the glucose is not supposed to soak in topically. The fact that it drools down their neck doesn't raise their blood glucose level. It comes in several flavors. They say they're delightful on the side of the tube. I don't think that's always true, but when you're hypoglycemic, nothing tastes good anyway. And so these tubes of glucose contain varying amounts, but we're going to give the whole tube. Whatever you've got, you give the whole tube, just not all at once. Don't squirt the whole tube in between their cheek and gum. It's going to run off. But the huge issue here is, can they swallow and maintain their own airway? And that's a judgment call. This is a gray area. It's not always black and white. And I think when in doubt, you need to assume that they can't manage their own airway. We don't want them to aspirate this. We don't want the glucose paste to drain down their throat and go into their lungs. And so, can they swallow? Can they maintain their own airway? It's a judgment call. That patient that's not responsive to nail bed pressure is unlikely to be maintaining their airway. That person that is responsive to some painful stimulus with nail bed pressure is probably safe enough. It's a judgment call. When in doubt, hold off. While this is rather time critical, in most cases, if you're in a BLS first response role particularly, you have ALS providers coming behind you, and in most cases, the differential between the time you're ready to give the glucose paste and the time the medics are going to walk in the door is just a matter of a few minutes. And so let's don't put someone into an airway problem just trying to save 4 or 5 minutes. If you're looking at 20 or 30 minutes, then you may have you do then have a harder judgment call. But make decisions based on what's going on right now in this situation, and make a judgment call. But let's don't be pouring glucose paste into a patient that can't even swallow. All right, so that was hypoglycemia, low blood sugar. Well, what about hyperglycemia? And so usually what are we talking about here? Well, with hypoglycemia, we're talking about blood glucose levels probably under 70, in the 60s or 50s, for them to show up with symptoms on the hypoglycemia side. On the hyperglycemia side, it's 300 plus, usually higher than that. Many field glucometers only go up to like 500, some 600. And when you go over that, the glucometer simply says high. So if your glucometer is saying high, then clearly that patient is hyperglycemic, and they're hyperglycemic at a level that should be causing symptoms. Again, this may not be the only thing causing their symptoms, but it certainly is one thing causing their symptoms. Patients can have more than one thing wrong with them. They don't read our books, they don't read our protocols, and they don't just limit themselves to having one problem. And so while you have found one problem, you may not have found all the problems. So you should continue to do assessment, continue to run down your list of things that may cause altered mental status, but you've at least found one, and that would be the hyperglycemia at a blood glucose reading of 3, 4, 5, 600, or even high on your glucometer. Now, whereas with hypoglycemia, you can do some things, although you have limited tools at the BLS level, you at least have glucose paste, and you have the option possibly for oral intake of snacks and drinks. On the hyperglycemia side, you've got nothing. The problem is the patient did not take their insulin or did not take their type 2 meds but they have eaten. And what do they need? They need insulin. And we don't have insulin in the field, not even at the ALS level. Insulin has to be refrigerated. And so, again, don't mess with the pumps. Don't try to up the flow on a insulin pump. Let the medics make that decision if they're going to go that route. And so these folks usually don't get sick in a hurry. The hypoglycemia patient, that can come on pretty rapidly in 15 or 20 minutes or something. But the hyperglycemia patient, that usually is a much longer thing over several hours. And so your history of present illness can help you as well. On assessment, these guys don't look shocky. They look sick. They look like they have the flu or something else. They may have some nausea, vomiting, but not always. They may have this fruity odor to their breath, and some people describe it as fruity. I have never understood it to be fruity. I can't explain what it is. I know what it smells like. I grew up with a diabetic. My father was diabetic, type 1, since he was 17. So I had the advantage of knowing what that smells like, and it never smelled fruity to me, but whatever. And that's one of those things that I wish we could bottle up smells and help you in class learn these smells. But that's one thing for clinicals, and when you're on a call where this is identified, it would be excellent for you to experience that. Kind of in general in EMS, we don't like to lick or sniff things, but in this case, this odor is fairly diagnostic of what's going on. That it will not be present in the hypoglycemic patient. It's present in the hyperglycemic patient due to the ketones that are being produced and exhaled in their body. So anyway, what you can look for and will be able to assess for is hyperventilation, in that they are breathing rapidly and deeply. And what's going on there is that they have a metabolic problem that their respiratory system is trying to correct. They have a metabolic acidosis that's being corrected by a respiratory alkalosis. I don't need you to know those terms, but some of you do know those terms from prior learning, and so I want to just connect the dots there. So it's a respiratory alkalosis that's compensatory for metabolic acidosis. And this condition is frequently known as DKA, diabetic ketoacidosis. The ketone being exhaled there is the situation. So on assessment, you walk in, you find a patient breathing rapidly and deeply. They appear to be ill, they're altered, and you do CVO, and then because they're altered, it leads you right to a temperature check, it leads you right to a glucose check, it leads you to a more detailed history of present illness where you're looking for other signs, you're doing a sample history, you're trying to find any meds, you're trying to assess for drugs and alcohol, and you have a lot of things to consider. But what I need to caution you on is that CVO is what matters. Playing detective comes after you've played EMT. So you need to manage that airway. Snoring should not be happening. When people are snoring in front of us, we need to wake them up or open their airway. Maintain ventilation and oxygenation. And again, with hypoglycemia, you won't see hypotension. With hyperglycemia, you could. So check for hypotension, check for shock, manage it as standard management. The ALS treatment for this will involve lots and lots of fluids, as we'll talk about. So again, manage that CVO as normal. Insulin is the fix. We don't have that. ALS doesn't even have that. ALS will use large amounts of IV fluid boluses. And then what happens if you don't have a glucometer, your glucometer is malfunctioning, you can't get a good finger stick, whatever. You are unable to measure their blood glucose. Does that tie your hands? Well, it certainly complicates things, but here's what you must remember. When in doubt, and you have a blood sugar related issue, if you were to give the patient some glucose paste, if you were to give the patient some glucose paste and they turned out that they really were hyperglycemic, a little bit more glucose that you give is not going to make any difference. Who cares? Big deal. But if they were hypoglycemic and you couldn't measure it because your glucometer's not working, and you give them some glucose paste, it may fix the condition. So when in doubt, and in doubt means you can't measure the blood glucose, you should give glucose. But again, use the history, present illness, use their past history, think, and make judgments. So, summary to this, altered mental status in general, manage that CVO as normal. Airway. People should not be snoring. People should be ventilating normally. Start with simple stuff, positioning and jaw thrust, and kind of hold back a little bit on these altered mental status patients. Hold back on your oral and nasal airways unless you absolutely need them. And as we'll talk about overdoses and things, to use nasal airways in these patients, at least to use 2 to stop up both nares with an NPA doesn't help you. So be careful. And remember, these can be more than one thing. The heroin addict can also be hypoglycemic and hypoxic, and on and on and on. So there are many causes of altered mental status, and many times more than one is also present. So we'll do a lot of this in lab. We spend a fair amount of time proportionally on altered mental status cases. And the big idea that we will coach you in the lab setting is manage CVO, play EMT first, then play detective and try to figure out what it is. At the EMT level, there's very few things you can fix, even if you can thoroughly investigate and definitely determine. But CVO, we've got to manage. And don't let your patient be hypoxic and hypoglycemic. That's just silly. So that's the end of this little presentation, and we'll see you in the lab.